I don't know where I am. Let me see. Let me see.
Hakuna reason ya hiyo group.
Yeah, there's somebody else in a meeting. No? Give me a minute. Let's see. Okay. Okay, where am I now? I think I'm lost. Okay, is that my screen? Is that my screen or somebody else's screen? Are you able to see the title?
Yes, we can see it.
Yes, we can see it. Okay, thank you. So we are discussing that. Okay, is there another meeting going on? So we are discussing cardiac biomarkers this morning. And just so that we can have the context of our discussion, we all appreciate that non-communicable conditions are increasing globally. And in the developing countries, we are challenged with the double burden of increase in communicable conditions, including the neglected tropical diseases. And then because of changes in lifestyle, we are also catching up with the rest of the world with regard to non-communicable diseases risks. So we know that hypertension is on the increase, diabetes mellitus, dyslipidemias, all of which are known to be risk factors for coronary artery disease. However, we also have other cardiac conditions which lead to heart failure from childhood, congenital heart diseases, rheumatic heart disease, and then of course among the adults, the risk factors for coronary artery disease can also predispose to heart failure. Is that noise coming from my end? So that I can, these technologies, or somebody else.
No, sorry.
You're managing the muting of?
Yes, I'm muting the people joining. So as they join, they're unmuted. So I need to keep muting them. Sorry.
Oh, okay.
You may proceed. Yes.
Okay, fine. So we do have biochemical markers which have been found to be useful in management, in diagnosis and management of the most prevalent heart conditions, that is heart failure and ischemic heart disease. I think it is in this context that we are going to discuss cardiac biomarkers. So this is just a depiction of the global burden of cardiovascular disease. I think globally, this is the 2017 data. It's showing that cardiovascular diseases were the most common cause of death around the world, followed by cancer. Yeah. And then other conditions, you can see what will be number one in Kenya at the same time. Around the same time is fairly low on that on this global picture, HIV/AIDS, TB, etc. So when we come to our local data, the Kenya Health Strategic Plan of 2012 to 2017 listed ranked conditions which were causes of injury and death among Kenyans, and ischemic heart disease was number 8 in the Kenya Health Strategic Plan 2012-2017. Then when we come to the fact file, the Kenya top causes of death in 2017, which would be now equivalent of the world data 2017, we find that cardiovascular diseases are ranked 6. So there is an increase in conditions, cardiovascular conditions, which are becoming an important cause of morbidity and mortality. So just recapping on the myocardium, because these biomarkers are related to myocardial injury. We know that the myocardium has bundles of striated muscle fibers, and these fibers contain specific proteins, which are actually cardiac specific. That is actin and myosin, cardiac specific proteins. And then we have regulatory proteins, which are known as the troponins, and the contraction or the cardiac muscle activity requires enzymes for energy transfer as well as proteins, which include myoglobin, creatine kinase, aspartate transaminase, and lactate dehydrogenase. So it is these enzymes and proteins which arise from normal cardiac function, which then would be released in high quantities when there is necrosis of the myocardium. And that release is what has accorded them utility as cardiac biomarkers. Yeah. So they don't come from any URS. They just, as a result of injury to the myocardium, you get release of the contents of the myocardial cell. And so studying their release is what now allows us to reflect back that myocardial cells have been injured, myocardial cells have undergone necrosis. And that then provides a diagnostic and a monitoring utility. So we define biomarkers as substances which can be used as an indicator of a biological state. So they must be objectively measured. So it would be a characteristic that can be objectively measured and evaluated as an indicator of either normal biology or a reflecting of a pathogenic process. So when it comes to cardiac biomarkers, then there are substances which are released from the heart muscle when it is damaged. And this damage can be due to inflammation, can be due to ischemia, or ultimately necrosis. So it is appreciated that they must be coming from the heart muscle itself. So how do we classify them? You can appreciate because the cardiovascular diseases globally are the #1 cause of death. There is a lot of investment in the in vitro diagnostic industry with regard to finding biomarkers for cardiac conditions. So if you go into the literature, you'll find a whole, there a lot of work has been done to try and identify biomarkers, but the ones which have entered the clinical realm are not as many as you would find in the literature, but a lot of work is still going on, particularly in the West, to try and find, is there one which can, that make a diagnosis at the earliest time, determine risk and all that. So I've just provided a few of those examples of a few of the markers so that we can have a full context. There are those which are indicators of inflammation. It is accepted now that coronary artery disease is triggered by inflammation, so that there is ongoing mild inflammation, which leads to the formation of those plaques in the arteries, and ultimately they rupture and all that. So markers of pro-inflammatory markers have been explored and utilized, including CRP. And CRP here, we're looking at what is known as highly sensitive CRP. You know that CRP is also used in sepsis, in inflammation due to sepsis and all that. So highly sensitive CRP is low levels of CRP elevation. Then we have lipoproteins, PLA2, homocysteine, which are also risk determinants. Then there are markers which have been explored to identify when there is a rupture of the plaque, atherogenic plaque. These include what I've put there, soluble CD40 ligand, placental growth factor, PAPP. We rarely use them here because most often the patients with the ischemic heart disease will usually will present when there is already a myocardial infarction. So the plaque rupture is, we don't have these available in clinical use in our setup. At least I haven't seen in any lab. Then also these are the markers of ischemia. Again, those would be for early, rarely used here, but it's good to know because that's where we will be going to: ischemia, modified albumin, and bound free fatty acids, among others. The ones which are mostly used are the markers of necrosis. So this is the patient who has acute myocardial infarction. Yeah, and from the profile of myocardial proteins and enzymes, you can see all the contents of the myocardium have been tried and used as markers of necrosis. From the enzymes there, the three enzymes which have been most widely used: aspartate transaminase, lactate dehydrogenase, and creatine kinase, and particularly the MB isoenzyme of creatine kinase, then myoglobin, and now we are in the troponin era. Yeah. So from this list, the ones which the cardiologists here have utilized most often, from the pro-inflammatory, highly sensitive CRP and homocysteine. Some cardiologists would assess for homocysteine, because we know that hyperhomocysteinemia is a risk factor, and then the markers of necrosis. Then we also have markers of myocardial stress. Myocardial stress is when there is now a stretch of the myocardium, which then stimulates the production of B-type of natriuretic peptides. So BNP, and particularly what has entered the diagnostic realm is the B-type natriuretic peptide, which is then used to indicate heart failure. Myocardial stress occurs with the stretch, and the stretch occurs in heart failure. So we usually have the markers of necrosis and then the markers of heart failure. That will be the scope of our discussion this morning. So for any biomarker, there would be what would be referred to as the desirable features to make the biomarker clinically useful. So with regard to markers of necrosis, then it is desirable that the marker should be highly sensitive and highly specific. I hope we know what sensitivity and specificity of diagnostic assays means. And then it is also desirable that they should rise and fall rapidly after an ischemic episode. The assay itself should be reliably measured, and the results should be uniform because serial analysis would be done. They should be simple to perform. And then the turnaround time, it is desirable that it should be less than 60 minutes, because that is about the time when it takes for an ECG also to, even less than 60 minutes, so that you have results of ECG and the biochemistry markers for early decision making. Because the earlier a diagnosis of acute myocardial infarction is made, the better the prognosis for the patient. So you don't want a marker which will have a very high turnaround time, in which case that they're losing time to improve the patient outcome. And also desirable that it should not be significantly influenced by kidney dysfunction, especially the kidney dysfunction shouldn't influence the concentration of the biomarker. And among the cardiologists, they would use the cardiac markers for risk stratification in a patient who is an acute coronary syndrome patient, but most importantly for diagnosis of acute myocardial infarction. Some have been used for prognostication, and then the B-type natriuretic peptide in heart failure. The troponins also play a role in heart failure prognostication. So with regard to acute myocardial infarction, the diagnosis of acute myocardial infarction, the diagnostic criteria have been changing over time. And in the early 1970s, it was that there should be an equivocal pathological QF that is on ECG, and a history of angina, and elevated. That time it was enzymes, the 3 enzymes. It was not the other biological markers. So there would be history of ischemic pain, the typical angina pectoris, and then ECG and elevated enzymes. And in those early guidelines indicated any 2 of those 3, typical chest pain, typical ECG, typical biochemical findings would be sufficient for a diagnosis of AMI. So if a patient has characteristic chest pain and ECG was also typical, then the biochemistry wouldn't be necessary for diagnosis, but it would be done for follow-up to see whether the response to treatment. Yeah. And so in those early days, then the enzymes, or what were the cardiac markers then, were this triad. So, you just request for the cardiac triad, and we would know in the lab that we are going to do CK, AST, and LDH. There were, however, limitations in these enzymes. Specificity was low. Remember, that is one of the desirable characteristics, that they should have high specificity. But specificity was low because these enzymes are also found in almost all the cells. CK is a muscle enzyme, and the skeletal muscles are much more than the cardiac muscle. So any skeletal muscle injury will lead to CK elevation. So you can see the non-specificity. AST is found in the liver. It is found in red cells. So a patient with severe hemolysis, for example, would have AST elevation much higher than one who is having a myocardial infarction. Likewise, for LDH, it is also found in most tissues. So they are quite non-specific. And then sensitivity is with regard to how fast will these markers rise following an infarction. And there is a lag period. between about 3 to 6 hours following ischemia is when these biomarkers would rise. So those are the main limitations. But a patient who, for most patients with acute myocardial infarction, these enzymes would still be raised. And so if you're in a setup, if you're practicing in a setup which doesn't have troponin, you can still revert to this triad. They have stood the test of time, only that they are more newer, more sensitive, more specific markers. Not that they are too bad. So this would be the typical picture in a patient with acute myocardial infarction if the cardiac enzymes were used. CK would start rising from about 3 to 4 hours after ischemia, and the peak CK value would be between 1 to 2 days, and by day 5, if the patient survives, by day 5, the CK would be normal. AST also starts rising 6 to 8 hours, peak at the same time around 1 to 2 days, and by 4 to 6 days, it has normalized. LDH would be what was referred to as the late marker, because it will start rising about 12 to 24 hours after ischemia. The peak is 2 to 3 days, and it would remain elevated up to 10 days. Only there is a 0 which seems to have dropped off the table. So it is 7 to 10 days. So LDH would be a late marker. Yeah. And the CK and AST would be the early markers. Yeah. So from that table, you appreciate that the enzymes would increase at different times, and they're also cleared at different rates. So the timing of the specimen collection would become important in interpreting the results. So that if a patient presents very early, then you may get a false negative if the enzymes are not elevated, if it is, say, before 4 hours. Yeah. And so that requires that if there is a high clinical suspicion, then the doctor must, you needed to know that there is this lag period so that you do not discharge a patient whom you are perhaps suspecting that it could be an AMI and the ECG is not typical. You don't discharge that patient, they will die at home. If you make a false impression of that, no, now the enzymes are normal, this is not AMI. And the patients have been lost. Patients have succumbed at home because of this misjudgment. So if the history is highly suggestive, keep the patient at the A&E and repeat. And that is what we see good. If a cardiologist is on the scene, they would not discharge the patient. Yeah. So just to internalize those cardiac enzymes, and also for me to get my breath, I'm showing you results of a 57-year-old hypertensive, and I'll ask some questions and you can put your views on the chat and Han can read for us. So this gentleman is 57 years. He has been admitted with a diagnosis of COVID-19, and a series of tests have been done. ALT, AST, LDH, total CK factor. They did a whole battery of cardiac enzymes. CKMB, troponin I, and since we have read the history, let me scroll down. And NT-proBNP. And the results are there, and the reference ranges for the markers I've also provided. So what would be your impression? What would be your impression with regard to this gentleman? And if there are any responses, because I cannot see the I cannot see the chart. Maybe I'm the one who is not technical savvy, but I cannot see the chart when I'm presenting. So what is your diagnosis and why? If any diagnosis. Is there anybody with an impression? Oh, okay, I can see the chat box, I think. Okay, so Adan says there's an AMI. Joshua Karanja says an AMI that has progressed to myocardial stress. Vanessa thinks it's a cardiomyopathy. Okay. And Njogu says it's an AMI due to high LDH. Why did you pick on LDH? You don't have to answer that. Okay, Kelvin says an AMI at least 3 hours ago, my myocardial infarction progressed to heart failure. Okay, so all those thoughts can be rationalized from the results. Yeah, all those thoughts can be rationalized from the results. You have all the three cardiac enzymes being elevated, which would support an impression of an AMI using the old criteria. CKMB and troponin are also raised, which would also support an AMI with the current criteria. And then NT-proBNP is also elevated. And so some of you are thinking that the cardiac stress is arising from the AMI. Yeah, the cardiac stress is arising from the AMI. Yeah, but remembering that this is a hypertensive patient, it could be the reverse as well. Yeah, hypertension can lead to heart failure, and heart failure can then predispose to necrosis. So it could also be that this is a patient with heart failure and now having minor myocardial injury, which is being reflected by the troponin and the CKMB and this enzyme elevation. Yeah. So the relationship between acute myocardial infarction and heart failure is intricate. Heart failure, meaning that there is pump pressure, which indicates that there is a reduction in the blood flow to the periphery. And that periphery includes the heart itself. So the heart also suffers the consequences of heart failure, so that you have also ischemia, just like you have ischemia in the periphery due to heart failure. And that could also contribute to that. Yeah. Yeah, but you are appreciating that all the biomarkers are elevated in this patient. Yeah. And so, of course, now things like an echo would indicate which is the predominant. Is it the myocardial stress, which is driving the ischemia, or is it the ischemia which is driving the stress? So thank you for those contributions and your thoughts. So when we look at now at the enzyme specifically, CK, CK has 3 isoenzymes, which have been named the MM, MB, and BB. Yeah, because it is a dimer. It is a dimer made up of it is a CK. Is it a dimer or yeah, it is a dimer. So and there are 2 possible units, M and B. So the combination of these 2 units then can give possibilities of 2 M's, 2 B's, or an M and a B. And the MB isoenzyme is the one which is predominant in the cardiac muscle. Yeah. So in myocardial infarction, both total and the CKMB isoenzyme would be elevated. And but the MB isoenzyme is predominant in the heart, comprising up to 40% of the total CK. So if there is, if one wants to differentiate whether the elevation in CK is as a result of myocardial infarction as opposed to skeletal muscle injury, then the ratio of CK MB to CK has been used. And in normal individuals, the ratio is usually less than 6%. But in acute myocardial infarction, the ratio is elevated beyond 10, up to even 30% would be of the CKMB fraction. Yeah. So CKMB, it is predominant in the heart, but a bit of it is also found in skeletal muscles. So somebody with having rhabdomyolysis, you may also find CKMB being elevated. But then that is when you need the CKMB-CK ratio becomes important so that you attribute appropriately whether you're dealing with MI or skeletal muscle injury. And I've given some of the sources of skeletal muscles, total CK elevation more than CKMB. Then aspartate transaminase, we know a lot comes from the heart, liver, skeletal muscle, so it is non-specific. It is quite sensitive in terms of you'll find it is elevated, but it is non-specific. And in the patient we have just considered, you will find when there is a disparity between ALT and AST, yeah, because both of these enzymes also come from the liver, which we will discuss when we discuss LFTs. When you find AST is higher than ALT, then you must consider a non-hepatic source for the AST elevation. So you look, is there hemolysis? Yeah, many times when I will ask the attending physician that, has malaria been excluded for this patient? It is a common cause of AST elevation greater than ALT. But in the context of if there is a history of a cardiac condition, then you know that most of this must be coming from the myocardium. Then LDH as well. LDH as well is quite non-specific, and most often nowadays we don't use it in AMI. Most of the time, LDH now we use as a tumor marker to indicate neoplastic elevation. So what would be the value then of still using using enzyme? In the early diagnostic criteria, they were most useful in a patient who did not have typical features of AMI. Yeah, and serial estimation would be used, and the cell would be used to identify if there is a reinfarction. You know, once a diagnosis is made in a patient with the AMI, then the serial estimation of the marker is done to check the progress of the condition. And if there is a reinfarction, then you get a second peak in the enzymes or the other biomarkers. Then the biomarkers are also useful in what would be referred to as silent infarction, like diabetic patients, coma. I remember a patient who presented to an orthopedic surgeon with clavicular pain, you know, just some funny skeletal muscle pain. And the good obstetrician, not obstetrician, the good orthopedic surgeon suspected an AMI. And this time they were using troponin, and troponin was very high. The patient, of course, had an AMI, late presenting probably, and it was diagnosed, and the patient was appropriately managed. Yeah, and for these patients with atypical presentation, I also remember a patient who just went to see their cardiologist with vague symptoms, and he was walking, and the cardiologist sent the patient to the lab for, just say, let us just check the CKMB. And the CKMB was about 10 times the upper reference limit. And, I was in the lab when my colleague who ran the test, and can you look at this? Say, what? And wow, this is a patient with AMI. But the patient is just sitting out here. The patient had walked to the lab. This was an outpatient. Said, this is an AMI. So we called the cardiologist and told him, yeah, you sent a patient here who is having an acute coronary syndrome. And, the cardiologist said, no, I don't think so. It was just a vague, your patient is having an ACS. And because the doctor's clinic was not far from the lab, he said, okay, bring the patient back. Yeah, ask the patient to come back. And we were quite worried because of the values that we were seeing and we repeated. We escorted the patient back to the cardiologist's clinic. And for sure, by evening, that patient was in the ICU. So those atypical, sometimes the biomarkers are very useful because we say this patient goes home. If that patient had gone home, for sure that patient was going to may not even have reached their home. So when the cardiologist, I said, but why did you request for CK? I just asked him, why did you request for CKMB? You must have suspected something was going on. Yeah, and he was quite relieved when it was actually the troponins. When they were done, they were up in the sky. So they also use the cardiac biomarkers to assess for reperfusion. In the early presenting AMI, then they try to reperfuse the heart. And when there is effective reperfusion, then the peaking of the enzyme occurs quite early, not as I had listed. So then they know that yes, that blood flow has been restored. Yeah, but currently I see even with troponin, some cardiologists would still do CKMB to assess for reinfarction, and they're quite adamant to use that. So with the new markers are myoglobin, CKMB, and the troponin. So the AST, ALT, and the total CK have gone off vogue, but I'm emphasizing that you can still use them if you don't have these newer markers, which are a bit more expensive. Yeah. So with the new markers, myoglobin is what we refer to as the early marker. It starts rising from about 30 minutes, 1 hour to 4 hours, and peaks by about 6 to 7 hours. And by 24 hours, myoglobin usually would be normal. Then CKMB tracks with the total CK, starts rising about 3 hours. And usually by 3 days, CKMB will be normal. Whereas the troponins are now the equivalent, the late markers. They take over from the LDH with regard to their timing, and they can be elevated, troponin T particularly, up to 14 days, troponin I usually about a week. Yeah. So remember I said the lag period, yeah, before the marker is elevated, and knowing that would determine how the markers are interpreted. Yeah. So a brief about now we are in the troponin era of AMI. Most of the diagnosis now is anchored on troponins, and remember they are regulatory proteins. There are 3 subunits: troponin C, troponin I, and troponin T. The ones which have diagnostic utility are troponin I and troponin T. So that is just a picture of the troponins You can look at it when you're looking at the notes. I hope somebody's recording. Yeah. Yeah. So a bit of in most of our labs here, it's a troponin I is one which is widely used. And I had already shown the kinetics in that pattern. Interest of time, let me just scroll through. Yeah. Now there is, I don't know if I have it in the slide. Let me just have it here. Now between troponin I and troponin T, if you go in the literature, you'll find a lot of debate. You know, this one is better than the other. My experience is there is not significant difference. Okay, some literature says that troponin T is affected by a kidney injury, so that you can get misinterpretation in patients with kidney injury, but it is difficult to find discriminatory, sufficient discriminatory data. So my answer, what I go by is either you use T or you use I, you'll still get a good handle of diagnosis and monitoring in a patient with acute myocardial infarction. But because the two are provided by different companies, there is a lot of market share competition. Troponin T was the first cardiac marker. You can see the rise and fall pattern. I'd already shown it in the table. Troponin T was the first biomarker, new biomarker to come on the market. It is provided by Roche, and it was patented. So nobody could develop a cardiac troponin T assay. So all the other IVD companies, remember I said heart diseases are the most prevalent cause of death. So all the other IVD companies then went for troponin I. So there are very many troponin I assays, including from Roche itself, but there is only one troponin T. Yeah. So to maintain the troponin T, the fight for market share is what I believe causes a lot of debate between trop I, trop T. But both of them work quite as well. The issue with troponin I was an issue of standardization because they are immunoassays, and so if a troponin, you use troponin I, say from Abbott, and then you repeat with the one from Roche, there was an issue of standardization that the results would not be correlating. But a lot of work has gone into standardization, and now with what I'll mention shortly as high sensitive troponin I, significant standardization has been achieved. So look at this, gentlemen. We have these point of care. We call them cardiac triage. Point of care to achieve, remember, the turnaround time that is required. Under these point of care devices would have the three markers, CKMB, myoglobin, and troponin I. And this was done for this 73-year-old man. And the results are there. Can I get views on what is the impression? 1 minute. People kindly give your views on the chart. 73-year-old man, you can see CKMB, myoglobin, and troponin I. What is your impression? What do you recommend? Okay, thank you. I can see some responses here. Jasper says it's a very recent MI. Khadija is saying an early rise. Very early. Joshua thinks it's skeletal muscle injury. Okay. Bashir, rhabdomyolysis. Okay. Okay. Any other views? AMI in the past 3 hours. Okay. Okay. Yeah. So what we have is isolated myoglobin elevation. And I can see from the responses, like Bashir is asking, is this coming from skeletal muscle? That this may be coming from skeletal muscle. Yeah. And others are thinking this is likely an early AMI. Yeah. Considering that that a cardiac triage was done, it means clinically the attending doctor had AMI as a differential. Yeah. And on the basis of that differential, then one would consider an early AMI. So what would be done if myoglobin is isolated myoglobin elevation is a repeat would be done within 6 hours, so that you see whether the other markers will now rise. And the guidelines actually indicate that you'd repeat even for 24 hours. The patient would be kept in the at least within the health facility for 24 hours. If after 24 hours CKMB and troponin I do not rise, is when an AMI would be ruled out. So here AMI would remain still a possibility. It's only after 24 hours, that was the guidelines is when an AMI would be ruled out if myoglobin is the only marker elevation. So that is how the kinetics of the cardiac biomarkers would be used, yeah, to determine, how to triage the patient. Okay. So now with the current definition of myocardial infarction, highly sensitive troponin is actually at the seat of diagnosis of AMI. And what is the difference between highly sensitive, HS, I call it HS troponin. Yeah. In the old guidelines, troponin, if troponin is detected, then it means there is myocardial injury. But with highly sensitive troponin, now we have reference values for troponin, which is less than 19 nanograms per ml, so that troponin elevation is considered if HS troponin is greater than, why am I doing this again? Is greater, sorry, I'm scrolling through the guidelines. Kindly, please go and access these guidelines, which they give quite a good indication of how troponin would be used in acute myocardial infarction in the current setup. Yeah. So it has to be above the upper reference limit, which is currently 19 nanograms per ml. Yeah. And then the injury is considered acute if there is a rise and or a fall of the troponin values. If they remain constant, then you consider chronic injury, which is what may be found in heart failure. Yeah, if we had, I will, yeah, I've just lifted this from the guidelines, which you can go and read. Yeah. So in an acute AMI, just read the first bullet, that there is a rise and fall of cardiac troponin, but there is a rider. Remember I said that it is troponin based. There's a rider with regard now to the other clinical parameters, which would support a diagnosis of this type 1 AMI or acute AMI. ECG, clinical, and other imaging modalities, including angiography. And then there is what is known as a type 2. Yeah, and the type 2 is what now would be related to things like heart failure. So there is evidence of imbalance between myocardial oxygen supply and demand. Yeah, so other symptoms of myocardial injury, new ischemic pathological findings, etc., etc. So this type 2 is quite common. Type 2, oops, what have I done or what have I not done? Have I lost something? Where have I gone? Where have I, okay, what have I done? Yeah. I think this is where I was. So this type 2 is the most, quite common, and you would see it in patients with heart failure. We are also seeing a lot of troponin elevation in patients with COVID-19. Yeah, and they would fall into what I would refer to as the type 2 MI. So just an elevation of troponin, because it is very sensitive, does not necessarily make a diagnosis of acute myocardial infarction. In fact, I asked my cardiology colleagues that should we have a rider that troponin interpretation should, that if troponin is elevated, a cardiologist should be called in to put it in context. They haven't yet come with that. With a clear guide, but some cardiologists believe that they should put it in context, that it requires a cardiologist to put it in context. Otherwise, patients may be admitted into the ICU who do not need to be admitted, or others may be left out who need to be admitted. So that is how sensitive troponin has been, and how the big impact it has on the diagnosis and management of acute myocardial infarction. So coming to natriuretic peptides, I'll just say a few things because you only have like 3 minutes. That the heart would secrete these natriuretic peptides as a response to stress, myocardial stress, and their actions are to maintain blood pressure, plasma volume, and to prevent excessive salt and water retention, so that they enhance natriuresis, and by enhancing natriuresis, they also enhance water loss. So ANP was one which was initially identified, but later BNP was identified. And BNP is the one which has found clinical utility. So the actions are against the renin-angiotensin-aldosterone system. If you just summarize them, that they act against the activity of the renin-angiotensin-aldosterone system, and also decrease peripheral vascular resistance. Yeah. There are other activities which have been attributed to natriuretic peptides, but that is mainly the cardiologists to work through. From the clinical laboratory perspective, it is with regard to the measurement and what is it used for. Yeah. So BNP, you will read the biochemistry of BNP. I just want to focus on its utility. It is the biomarker that has been recommended for heart failure, either to detect or rule out heart failure, and I see also in the monitoring of heart failure management. So most of the cardiologists, at least the ones that I've worked with quite closely, will use the initial BNP value to determine, how well they are managing their heart failure patients. Yeah. So let me show you this. I think this will be the last case that I have. So this is a 65-year-old, a diabetic, who has general weakness and fatigue. And the assay that is most widely available is what is referred to the N-terminal proBNP. And that is the result. And for a 65-year-old, the upper the cutoff limit that we use is 900. For younger, it is 500. And then a troponin was also done for this patient. Yeah, and this is highly sensitive troponin. You'll see that the results are the reference values are different from the earlier troponin which I gave, which was just troponin. So troponin was done on admission, and it was raised. Remember, I said the reference limit is until 19. However, diagnosis of AMI is made as a troponin greater than 100. So between 19 and 100, if there is an elevation between 19 and 100, then you look for a delta change, what we refer to as a delta change. A repeat should be done within 6 hours, and you look at how is that value compared to the initial one. And the interpretation I have given here, a change between time 0 and time 2 of greater than 10 nanograms per ml would be a significant change. Okay. So let me have views here as we are finishing. So what is the impression for this 65-year-old lady? Does she have an AMI? That is a clinical question. The heart failure is not in doubt. Yeah, the NT-proBNP value is clearly indicating heart failure. But does she have an acute myocardial infarction? What are the views? Are there any views? Yeah, DJ is saying heart failure. Yes, we are agreeing. Heart failure is not in doubt. Does she have an AMI? Does she have an AMI? Okay. No AMI. Melanie, no AMI. Mohammed, no. Wycliffe says no. Yeah. So this is that now type 2. Yeah, or chronic. We used to call it minor myocardial injury until this new definition of AMI of AMI came in. Yeah, so there is not having an acute myocardial infarction, but there is evidence of myocardial injury. Yeah, this is a chronic myocardial injury which would arise in patients with heart failure. We used to call it minor myocardial injury before, but now it has been redefined to that type 2 myocardial injury. So it is not an acute myocardial infarction. Yeah. So at least we've all gotten that. So you can, and that was, like I said, that was the last case. So you can read the additional guidelines with regard to cardiac biomarkers so that you can have a full context of it. Is there something here which I didn't miss? Please repeat the explanation on delta change. Okay, Cynthia. Yeah, which is here now. Yeah. So I said the highly sensitive troponin, the reference limit, the reference Yeah, the reference range is 0 to 19 nanograms per ml. That is what the reference range, that is what some people call the normal range, but we don't use that term normal. Yeah. But then the diagnosis of acute myocardial infarction is made with a troponin greater than 100 nanograms per ml. So then you have a gray zone between 20 and 100. Yeah. So if the troponin falls in this, I'm just calling it arbitrarily, a gray zone, it's not gray, but if it falls between 20 and 100, then the guidelines are that a repeat should be done so that you are looking at the kinetics of the troponin. You're asking, is it rising? Remember, for the diagnosis, you said that you want to see a rise and then a fall. So you check, is it rising? And the indicator of significant rise is if the troponin between your initial assessment, that is your time 0, and time 2. And time 2 is usually anything from 6 hours. Yeah, some have brought it down to about 2 hours, but that one you can read in the guideline. So time 0 and time 2, if it is greater than 10 nanograms per ml, then that is the delta. That is the delta. And so if delta is greater than 10, then that is a significant rise, and then you would classify that as an acute myocardial injury. If, however, the delta is less than 10 or may even be lower, then that is not an AMI. So that would fall into the what I would call minor myocardial injury or type 2 myocardial injury, which is not acute myocardial injury. So this patient, 58 to 60, is just about 2. So it is less than the delta of 10. And that is why we are all agreeing that it is not an acute myocardial infarction. Is that clear, Cynthia? I hope that is clear, Cynthia. Okay, somebody has a question here. Why is ALT elevated? This is Stanley. Okay, let me see what other question there is. Why is ALT? And what else is here? In the first case, did the diagnosis have any significance with the test results? That is Melanie. Okay, let's go back to our first case, the COVID patient. Where is he? COVID patient. Why is ALT elevated? Where is the patient? Okay. Yeah. So ALT is 54. Slight elevation, eh? Remember, COVID-19. Okay, maybe I can answer, I think, Melanie's question first. That is this related to COVID? Most likely, yes. Most likely, yes. We know that COVID with the severe sepsis that arises during the storm affects very many organs, and the heart is not spared. But this is a patient who is already a non-hypertensive, so may already have been coming in with the heart failure, so that any now further compromise due to COVID-19 would worsen the impact on the heart. So it is difficult to completely silo what contribution is coming from the fact that the patient is hypertensive and what is new as regards to COVID. So if there's a patient who was being monitored quite frequently by a cardiologist, they would be able to give that difference, that what is a new finding. Yeah, but both are possible. Yeah. So ALT, we also know that COVID-19 does affect the liver. Yeah, so it could be the liver being affected, but we also know that ALT is also found, as much as it is quite specific to hepatocytes, you also find ALT in many other tissues. So it could also just become from the heart, but it is not significantly so from the heart. That is, I think that was Stanley who was asking. Yeah, so it could be a COVID impact on the liver. Some of it could also be coming from the heart, but it is not a significant elevation that we would be unduly concerned about. Is that okay, Stanley? Was it Stanley? Yeah, it was Stanley. Okay. Okay. So thank you very much. I think we can stop there. We will come back to enzymes when we are discussing diagnostic enzymology. We'll discuss now in more detail the liver, the LTST, not much of LDH, CK with regard now to skeletal mass. Okay. So over to you, Khan. Yeah, so in the absence of I think we are done. I don't know how to get out of here. Blah, 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 blah. I don't know. I don't know where I am. Can I? Oh, stop share. Oh, there we are. Okay, I think we are done for today. Am I the one to stop recording? I did it. I wasn't recording.